Thank you very much and welcome everyone for this third day of Pafcic, and we're going to be starting with an important session on structural heart intervention in Africa. We have seen yesterday quite sophisticated structural intervention from Los Angeles and somewhere else and from Stockholm with TAVI procedures, mitral valve clip, valve-in-valve. Procedures that are not available yet in Africa, but we will, I hope we can achieve that in the next few years. But we're going to be discussing today about a procedure that is being done for quite a number of years in many African countries, but it's not available in many of other African countries. And that was the reason why actually we wanted to focus on this procedure. It can save a lot of lives and of young population. This is going to be a balloon mitral valvuloplasty session with a recorded case from Khartoum, done by our friend Ahmed Suleiman. Welcome, Ahmed. And then we will have two lectures about the procedure. Now, it's my pleasure to introduce the panel. Professor Shakir Qureshi, that does not need an introduction, and Professor Mario Carminati from Milan, welcome. Dr. Osama Rifai from Cairo, Egypt. Dr. Ruben from Tanzania. Nisma Bindara from Rabat, Morocco. Emi Okello from Uganda. And Kees Batik from Djerba, Tunisia. So without any further delay, I will ask Chuck to moderate this session. Go ahead, Chuck.
Thank you very much, Habib, and welcome everybody and all the attendees. Reasonably early start, and it's going to be another interesting session for everybody, I'm sure. And it's my pleasure to welcome Ahmed, who has a recorded case for a mitral valve ballooning. So Ahmed, when we're ready for your recorded case, let's play. Thank you.
I think we're ready. Maher, can you play it? Yes.
Our case today for PTMC is 20 years female. She's para 4+0. She presented with symptom of heart failure and found to have a severe mitral stenosis with mitral valve area implanometry 0.7 with no MR and moderate TR with Wilkin score of 6.
Good morning. Welcome to Shab Hospital Cath Lab. Today we are doing this live case of balloon mitral valvotomy. And we have our gear ready. But first, let me introduce our team. Will be assisting me in the procedure. Abdul Latif is one of our allied professionals in the Cath Lab who is very active and well known to many. Hussein is our radiographer. And we have Nafisa, so Nafisa over there. She will be helping us with the imaging during the procedure. We are prepared. We have 2 trolleys here. Let me just go quickly over the tools we have for the procedure. One of the vital steps is the transeptal puncture. It's the key to a successful mitral valvotomy. This is our transeptal needle made of stainless steel. As you can see, it has a body, a sharp end, and the hub, which has a marker, which tells you exactly where you are in relation to the septum. To deliver the transeptal needle, we need the Mullins sheath. The Mullins sheath actually is made of an inside Mullins catheter and an outside Mullins sheath. Some people would use the whole thing, the outer sheath and the catheter. We are used here in Shab Teaching Hospital to go sheathless. We just use the transeptal, the Mullins catheter without using the outer sheath. And once we, and then also we have the septal dilator. This is a 14 French septal dilator, which we're going to use in a short while after we do transeptal puncture. Very important thing is to show those who are not familiar with mitral valvotomy, the relationship between the transeptal needle, the subrachnoid needle, and our Mullins. When we're introducing them, it should go nice and easy. And then, if I introduce the needle the whole way in, so the marker here meets the hub, look at the tip of the balloon, of the Mullins sheath. So now you can see the needle protruding from the tip of the Mullins. That's why we only allow this when we are puncturing the septum. Otherwise, during the procedure, we always keep the marker of the needle away from the hub of the Mullins sheath, usually about 2 fingers. And you can see that the needle is well within the Mullins catheter. Again, this is the marker which tells you exactly where you are. Generally, we perform a transseptal puncture for mitral valvotomy about 3 to 4 o'clock. All right? Again, we only do this introduced through the Mullins unless we are aiming to do transseptal puncture. We keep it inside all the time.
Ahmed, if we could just ask, stop the video for a second. And very quick question, Ahmed. How often what helps you determine whether you put an extra bend on the Brockenbrough needle or not? Any advice on that for everybody?
First of all, we'll look at the size of the right atrium. If it's dilated, it's not, in this case, not very dilated. The other thing is, when you come down, descend, you feel like the needle is floating, it's not touching the septum. So that you have, and then you make a bigger curve. You feel that the transseptal needle, or the Mullins with the transseptal needle end is almost floating. You're not able to get good contact with the septum, and hence you make a bigger curve there. So, imaging first, you get ready for it, and then what you get on descent of the needle coming down from the superior vena cava into the right atrium. If no good septal contact, then I make the curve of the transseptal needle bigger.
And any tips on when you're introducing a bigger curve inside the Mullins sheath or dilator? Any tips on when you're advancing?
Yes, I mean, when you make a bigger curve, it becomes not easy to introduce the Mullins sheath, the Mullins catheter. So you got to be careful. That's number one. You need a good assistance sometimes. They need to wiggle the needle a little bit slowly from side to side so that you can move it gently. Any resistance, don't push fluoro. I tend to avoid fluoro to the pelvis, but if you feel any resistance, you need to fluoro and make sure that it's within the Mullins sheath, it's not puncturing. And sometimes during a pelvic curve or a pregnant lady, you feel some resistance with that bigger curve. If your needle is within the Mullins sheath, sometimes you need to move the whole system together, get through the pelvic curve, and then slide the needles across through the Mullins sheath. So different ways to manage this.
Thank you. Habib, you were
yes, I mean, good question, Shaq. I think the changing the band in the needle, you do not need to do it straight away. So it is better that you start with the curve, the normal curve, the standard curve. And if you have a problem with that, like slippering of the needle, then you have to, as Ahmed was mentioning, then you have to adapt according to the anatomy and change the band. But maybe you don't know to do it, I mean, from the beginning. You have to start first and then you can do it. Now, the second question, the stylet that is delivered now with the Brockenbrough needle, it helps actually to introduce, even with the band, to introduce your needle inside the sheath. It did happen in the past that we did puncture actually the sheath with the needle. So the stylet could be a good way to avoid
protective.
A quick question for the method you're using. Do you do transesophageal monitoring, the procedure? Always, never, sometimes?
Oh, for me, we've done it only once. So almost never, because one TE probe in the hospital is very difficult to get anesthesia. So we've done it only once.
Okay. All right. Let's continue with the video.
Shaq, if you may make a comment.
Yeah, certainly.
It's an excellent question by Mario. You know, Mario, we have learned doing transseptal by fluoro before even TEE was available. So when you had TEE, you have to learn again, because now when we started doing left atrial appendage closure in our cath lab, we have started learning how to do transseptal by TEE. So it's another kind of learning. But your question
Yes,
is
yes, I agree, Habib. But you know, in our experience, sometimes we have a tough septum. Here, I think we should use the transvaginal. We did this several cases. Sometimes we fail by the fluoroscopy, particularly by the large left atrium aneurysm, and so thick septum. I think this is the indication for T.
Okay, let's carry on then with the video and Ahmed.
Okay. Balloon. This is our balloon. Patient height is about 160 centimeters, or a bit less than that. And we generally here, if we use a bigger balloon, we use a balloon about 2 points, but we start lower. So the valve diameter is about 26 millimeter. We take a 28 millimeter balloon, but we start with a 24 millimeter inflation. Me and Abdul Latif now, we're going to prepare the balloon now. This is a in-wheel-like balloon. This is the balloon, the shaft, and the two hubs. This is the main hub. This is the hub for inflation, and this is the ventilation hub. So we start by flushing the main hub, Abdul Latif, with just saline. So we flush the main hub. Excellent. And now we've flushed the side hub. All right. Good. And now it's time to test the balloon. So this is our inflation balloon. We're using here saline. Is that 3-to-1?
Yes.
So we're mixing 3 saline to 1 of contrast. All right. Getting with more. Okay. So now we're going to test the balloon. We're aiming for a first inflation about 24 millimeter. We generally like to do this underwater, so this is normal saline. So I'm going to show you this first here. That's how testing the balloon. So the distal portion goes first, then the proximal portion of the balloon, and finally the waist dilates. Oh, sorry. Deflate. Deflate all the way. So the balloon seems to work properly. Generally do that under saline to de-air the balloon well. So an essential part of the procedure is the airing of the balloon.
If I just ask for a pause there. And
Now,
pause the video. Ahmed, so in many parts of Asia, the balloons are re-sterilized and reused. What do you do?
we do not re-sterilize. We used to do that before. There's strict regulations, and there was a public outcry against re-sterilized materials, so we're not re-sterilizing.
Okay,
we're using these Chinese-made in-wheel-like balloons, and we use it only once.
Okay, Osama, what about in Egypt?
Yes, the same story. We used to re-sterilize for the high cost of the balloons. A few years back, the government issued strict orders to not re-sterilize anything. So it's around now 7-8 years. By the time we are fighting the hepatitis C, you know, that's why the government took these strict. I think they were right. We're facing problems now, of course, about buying the high costly balloon, you know. But this is the only way we can do it. I mean, charity organizations get through giving charity to the poor, buying them the balloons, but the government denies, and I think there are no re-sterilization. Now it's strictly using new balloons.
And what about Emmy and Ruben, if you could...
Yeah, we do. An interesting question there, Shaq. We still re-sterilize because we use the balloons made by Toray, and those are quite expensive. We have an industrial level ETO sterilizer in hospital. So we have this protocol that involves using, of course, we clean it very well, take it through Sidex, and then take it to ETO sterilizer. And it works well. We haven't had any issues. Of course, if we got the Chinese balloons that Ahmed is using, maybe they're cheaper, then that would be a way to go. But I wanted to ask you, Ahmed, At this point, have you given any anticoagulation? Once you got access, do you give anticoagulation before septal puncture or
Post.
afterwards?
And
Post
then,
puncture.
and Ruben, yeah, what do you do?
We don't sterilize, and we actually get donors from abroad, and we get them at a cheap cost, so we're not reusing them.
Okay, carry on with.
If I may say one thing, is that the balloon in Sudan, the balloons are supplied by the government, Central Medical Supplies, and this is a totally free procedure for the patients. So we don't have much say about the manufacturer, but we use what we get from the Central Medical Supplies.
I mean, it's good to see in other parts of the world they're still re-sterilized, but it's good to see that the governments have taken action in preventing re-sterilization of equipment. Yeah, go ahead, Habib.
Yeah, I think governments in Africa, they had the obligation of stopping re-sterilization, but they did not do what they needed to do, which is to make these expensive balloons available. You know, we thought that in Tunisia, for example, that we got rid of this disease, but now just because we were I mean, offering this procedure to many patients, and thanks to re-sterilization, I can tell you, we went up to 4 times, and we had even acquired some kind of expertise in re-sterilizing these balloons. But since we stopped doing so, now the waiting list is going up and it's enlarging. And this is a big issue. Now, I don't know what kind of balloon you're using. It's not the Inouye, Ahmed, right? Isn't it the original Inouye?
It's not the Toray. It's an Inouye-like balloon, obviously. I'll comment on the balloon, the difference between this balloon and the Toray. It's very floppy. It's more difficult to manipulate. And the shaft is complete translucent. It's just like flying, just floating markers in the heart. You'll see it when we go fluoro.
Is it significantly cheaper?
It is. It costs about $600. Toray is at $2,000.
Okay.
All right. Carry on with the video then.
Good. Excellent. Keep the balloon as low as possible. So you do it, okay? And now inflation time. So you want to test for 24. That's how we do it. That's the ruler there. Go up. Go up. That's 20 millimeters now. 21. Go higher. You take more. That's it. Yep. That's 24 millimeters now. Okay. The balloon's working well. It's now time to slenderize the balloon, and we have a stretcher here. And then this goes into the flushing it first. Okay. And then goes inside the main hub here. This piece here is important so that the slenderizer, can you push the slenderizer? Push. No, push. Okay. Good. Go. Look, the first lock. So here, first lock here, and then the second lock here. Unlike the Toray balloon, this is a Toray-like balloon, and there is no gold and silver. It's all silver and plastic here. Okay. Now the balloon is stretched or slenderized. We can take this part out. The balloon is ready to be used. A bit of extra gear is our stylet here to maneuver the balloon, and we have the pigtail steel wire, which is important to deliver the balloon across the mitral valve. Okay. So now we're going to move to the patient and start our
pause for a second.
work establishing.
Ahmed, any particular type of wire or any particular company or any advice on that?
No, we just, for the Mullen sheaths, we just use a regular 32 wire, and to for the balloon, this pigtail steel wire is supplied with the balloon. So using what the manufacturer supplies.
Okay, all right. Yeah. Okay, carry on.
Femoral axis, venous and arterial. So we have the 5 French sheaths in the radial, in the femoral artery, and then we have our 32 wire in the femoral vein. Now we're all ready for fluoro, so let's see where we are with the vein. So our wire there in the innominate vein. Okay. All right, we keep it there. So it's a good position. Good. So we have now the pigtail catheter, the aortic valves, to get aortic pressures as well as demarcate the level of the aortic valve. It's important to have that as a landmark. The puncture has to be below the aortic valve level for the mitral valve. Okay. And fluoro, so the Muller sheath goes up, and we park it here, right in the dominant vein, so we can take this out. So we're now sliding the, so it has to go nice and easy, gentle. I don't need a lot of floor to the pelvis. All right. So went up nice and easy. Good. So floor. Always to show the relationship between the transeptal needle and the Mullins. Always keep these 2 fingers away, 2 fingers away. And this is the pointer of the transeptal, about 3 to 4 o'clock. That's where we need the puncture to be. So always keep your 2 fingers like that. So we descend from the...
Ahmed, you sterilize the needle. How about the needle in terms of sterilization?
Oh yes, we definitely sterilize the needle. Just for the sake of this case, we use the new needle. The usual needle would be crooked like, so this was a new needle just for you, Habib.
I may have missed it, Ahmed, but is this lady with mitral stenosis pregnant as well or not?
Oh no, this is not a pregnant lady. She's 20, but she already has delivered 4.
Okay. Okay, very busy. Okay, carry on.
Aim for the first jump here. Go down a little bit, Hussein. Go down a little bit. Okay, so first jump, and then second jump. Okay, that's good. Now, if you look at the screen here, well, we try to have the puncture. You can see the pigtail catheter marking the aortic valve. You can see the left atrial border, very clear there. And our aim is to be in the middle between the pigtail and the outer lateral border of the left atrium. In the middle, about 1 vertebra below the midpoint of that line. Imagine a line between the pigtail and the outer border of the left atrium, midpoint, and we go about 1 vertebra below.
So can I interrupt a little bit? I have a quick question. Please, can you interrupt the video? Yes, Ahmed, don't you use the lateral view? We started to use the lateral view. You have started this a long time. I find it quite beneficial to be much below the aortic valve and not quite a low puncture. I mean, it's very, you can use it. You don't use it, probably.
No, we use it. It's going to come now. I think I don't want to ruin the surprises that's going to come. So yes, it's a series of not well positioned punctures, but I think we got through. It's a good teaching case in your mind. So we'll wait and see.
Okay.
Give a few minutes.
Okay, go ahead.
think the needle had moved, so I need to maneuver. It seems to have moved while we were talking. I have to get it up again. So the wire again, surgical wire. You have to do this safely. Yes.
Ahmed.
Okay.
Ahmed.
Yes, Habib.
Where did you puncture the artery for the pigtail? Is it in the right or the left?
Yes, we did it on the same side. Both on the left, both on the right side.
Of course, you can do that, but one of the tips is to try to do it rather in the opposite, in the left side, and the reason is to avoid any maneuvers displacing the pigtail from its place, and then you will lose your landmark. So it is good that you puncture from the left side, and you forget about it. Nobody will touch it, so it will be there. So one of the
yes. It's easier, it's easier to do that for you. Maybe we just try to avoid that for the young lady having both groins, you know. But anyway, we generally do it on the same side. I think if you notice that while we're talking, the Mullins catheter has moved, so we had to do another descent. And I think one point is always try not to go up with the Mullins with the needle up from the atrium to the nominate vein. You have to take the needle out, push your stereo wire, and then refeed the Mullins again with the. That's our first mishap.
Good. Carry on.
So over the wire. Okay. Flush. Okay. Syringe again. The needle again. Okay. Let's go. Let's go nice and easy. No resistance at all. Minimize fluoro. Okay. So here we are. We'll descent again. Yeah, you can focus on the screen now. Coming down from the vena cava. First jump. Second jump. Good position. Okay. So shall we go to lateral? You look at the transeptal needle here. Looks very bad position just below the aortic valve. So this is not good. It's a terrible position here. It looks like a good position. Yeah. So come down a little bit. Come down a little bit. So we aim for a position. And look here. We aim for a position between the pigtail head above the aortic valve and the pigtail and descending aorta, just below the midline there. So let's go back to AP. Make sure this position is good. Meanwhile, look at my fingers. I'm always keeping my fingers, keeping the. All right. Let's take a look here. Yes. Here, the puncture side seems a bit posterior.
Can I have a comment here?
Yeah, go ahead, Sama.
Yes, I think Ahmed is right. There's one tip here that me and the audience should take care about, is that whenever you change the position of the needle in the lateral view to be much more lower than the aorta, you should check at the same time, at the same position, the anteroposterior view. Because Ahmed, I heard you saying so, but I'm just laying stress on this point. If you don't do so, you may be in a very lateral part of the septum. And I think this is the case now. We are touching the lateral part of the septum, and it will be difficult to puncture the septum and even go to the mitral valve if you puncture in this position.
And that's what happened.
Thank you.
Yeah, we'll see. Okay, but I think it's also still reasonable to puncture here. Shall go back to lateral view? Though it's a bit unusual, but I think it looks good on the lateral. So we're going to attempt the puncture here.
So start to do puncture here. Okay. I think we've done the puncture. All right. Generally here, we like to first of all inject contrast. Make sure it's free flowing within the, yeah, can you loop it? You loop this one. So the needles now, we've made the transeptal puncture. And you can see we injected contrast and it's free flowing within the, and we have to keep the needle within the, all right. So we'll take the,
Ahmed,
shall we
just
go to
quick question or a tip, and that is, what about pressure monitoring at the time of pushing the needle into the left atrium? Do you do that?
I generally don't do it. I know it's good to see a transition from right atrium flat line and then left atrium pressure, that jumping pressure. But we generally don't. I don't do that.
Any others? Habib or Osama and others?
Well, for me, I usually do this. I cannot feel safe unless I have a free left atrial pressure, because you may be in when you're touching the left atrial posterior wall, and thereby you're going to have a damped pressure, not a free left atrial pressure. I think pressure monitoring doesn't take time. It makes you feel safe, and then you can inject as well afterwards. Habib, what's your opinion?
May I make a comment?
I mean, what I wanted to say, I mean, there are ways of doing this in experienced hands, and I know some of the operators that don't even use the pigtail catheter as a landmark because they're very much experienced in doing so. But in my opinion, I think it's better to do things the safe way, and I completely agree with Osama. So in our experience, we use the pigtail catheter, the pressure, and sometimes injection to be sure. And we would not actually push the sheath until we have the guarantee that we have a LA pressure and you have oxygenated blood coming back.
Yeah.
So you have to be really sure that you are in, particularly if you are a beginner or you don't have much experience with that.
Mario?
Yeah, good question. Shak, I had a question too. Okay, after Mario.
Mario, go ahead first.
Yeah, I mean, of course, I have a very little experience in that procedure because this procedure is very uncommon in our country, but also for this reason, just to have an extra safety measure, when I puncture the septum, just with the needle, I do not advance the sheath or the dilator. And I inserted, I do a little contrast, or I insert into the needle a 014 wire and advancing up to the left pulmonary vein. So I'm quite sure that the needle is in the left atrium, and I can advance the needle and the dilator then. This is just an extra safety measure for a person like me that is not a great expert in that.
Yeah, that's very helpful, Mario, because there are people, it's rare, but occasionally the puncture goes into the aorta, and that's the last thing you want to do is push the dilator there.
Exactly.
Emmy, go ahead.
Yes, I just wanted to ask about the level of the transeptal puncture. You know, yesterday we had these excellent cases about I think a case from Los Angeles about the mitral valve and valve and the mitral clip, you know, the imaging, in addition to fluoroscopy, of course, you know, they're using TEE. Some people use intracardiac echo. We do this a lot, just like Ahmed has done with fluoroscopy. But does it matter, you know, the height from the annulus? Does it matter for BMV, you know, where you actually puncture the septum?
Okay. Ahmed?
Oh, yes. I mean, I think now, you know, in mitral valve, as you know, the fossa valgus tends to become displaced inferiorly. I think it's important that to me, is central. We did a TE case before. I go for a central puncture. It has to be at the site of the thin septum. And again, if you look at the anatomy of mitral atrium in the mitral stenosis, the foramen ovale the fossa ovale becomes inferior displaced. But again, that's what you aim for. I generally aim for a central position at the thin part of the septum.
Okay, let's keep moving then.
Okay.
Pigtail wire going through the Mullins catheter. Okay, you can see it. You can see now we have the pigtail catheters inside the left atrium. Okay, thank you. Okay, that's a good nip. All right. Can you fix the wire? Okay, gentle on the patient here. Okay, gas passes through smoothly through the femoral vein, and then we take it up. Now you can focus up here. You see the septal dilator going through the septum. Though it looks a bit posterior, and on the AP, I think on the lateral looks good, and we'll see. I think it will go well. So we're dilating the septum now. We keep it, all right, so septum is dilated, that's a 14 French. And just make sure you don't kink. And then we'll take it out. Here, so the balloon should be ready. Septal dilator is out. Okay.
Just I've noticed if we stop the video, Amin has joined us. How often do you have to do, well, probably not nowadays, but emergency mitral valvotomies in pregnant ladies nowadays?
Yes, I think we do that. We've done 2 cases. One was presented in one of the other conferences, and without anesthesia, we had to do it with the patient propped up in 2 pillows, pregnant, with pulmonary edema, and hemoglobin of 7. So we've actually presented one of the Africa PCR. It won the best case of the Africa PCR. So yes, we've done a couple of cases where we have to intervene in an emergent way. And again, sometimes in our hospital, it's very difficult to get, there's very little support from anesthesia. You have to do things, you know.
And
Jack,
surgically, surgically?
Surgically or balloon? Oh, sorry.
No, we've got Amin joining us. He's a surgeon, so I was just asking him first. And
yes.
so if you unmute yourself, Amin. No, unmute.
Maybe ask Mayor.
I mean, you have to unmute yourself. Unmute. Vous êtes en muet. Il faut enlever le bouton.
He may be a surgeon, but he's not very good with the technology.
Is it good now?
Yes.
Because I just arrived and I didn't follow all the procedure.
No, my question was ladies pregnant ladies with severe mitral stenosis. How often do you have to surgically do valvotomies on them nowadays because of the technology, or you don't do them at all?
In our experience, we traveled. I work in both departments, and in our experience, we didn't operate them often. So we prefer trying this dilated procedure and to avoid problems of related to heparin and the problems of bypass.
Okay, Osama, what about you?
Yes, we have a relatively good experience. I did 25 cases, pregnant ladies, and we published some of them in I think one of the cases in Tanzania, the last CSI Africa.
Yeah.
It is very interesting. You wrap the abdomen and pelvis anteriorly and posteriorly by the lead apron. We use sedation. We don't use anesthesia, just sedation. And taking care of the lady, and we can finish the procedure in quite a short time with no injections of no dye injections and no angiography. I mean, try to minimize the radiation. And I will publish this soon, 25 cases. Mostly they go well. I mean, we got one case, premature labor, after she got some moderate mitral regurgitation. I mean, if something goes wrong, the fetus will pay the price. But otherwise, it goes well, and they give birth to a quite nice children without any problems during labor.
Okay, carry on, Ahmed. Habib. Yeah.
Minister, I think we have one of the largest in the world. I think approaching 100 cases. We have published that 3 times. With a follow-up on the babies, because one of the concerns is to have, if to look at X-ray radiation effect on fetus, and we have a follow-up up to 20 years on those kids. I think I have 1 or 2 slides on that on that particular topic.
Okay, all right, yeah. Carry on then, Ahmed. Video.
Can we go negative?
Negative.
No, you go more negative now.
Good.
Okay, good. Hold the wire. Okay. Okay. So that's why I find resistance. Okay. Okay. Sometimes you do find resistance. Just make sure the wire is well.
So, Ahmed, another very quick question. What's the profile of the balloon? What French?
This balloon is the balloon is 16 French.
Okay. So, any disadvantage or advantage to putting a bigger sheath in order to introduce the balloon more smoothly?
The only disadvantage is that it's not available in our cath lab.
Okay. Anybody else use bigger sheets in order to introduce this Inouye balloon, or direct?
I don't think there's any need, Chuck, to do that. I mean, most of the time it goes very smoothly.
Yes.
Or in the venous system, and then the most important thing is to dilate the septum. But with the dedicated introducer that comes with the Inouye balloon pack.
Okay, carry on.
If I might just make a quick question. In this case, in this case, a 16 French would have been very useful, and we'll see why. Again, most of the time it goes. There's a bit of a trick here we use sometimes to introduce the balloon when it's stuck at the femoral vein.
Yeah. Okay. Go ahead.
So wire well. Sometimes if you find resistance, one way, if you're well dilated, is to press. Look at here. Press. It's the head of the femoral vein. Press well, and then you can fix the wire. Okay. Okay, now went good. That's good. So well, you apply pressure. I got that now. Don't worry. So the balloon, I got the wire. All right. I unlocked the first part, hoping the balloon will pass through.
Okay, so if we just stop that for a second. Habib, I know it's a rare problem, but Habib, are you there?
Yeah, sure.
Okay, so I know it's a rare problem, but it's the tip is stuck. A bigger sheath would have helped in if you'd got that into the left atrium. Any reason again to avoid bigger sheath to help with the balloon passing?
To be honest, I mean, in the majority of cases, we don't have any issues, by the way, advancing the balloon. I mean, it did happen sometimes where actually the septum is quite difficult to cross, and the tip of doing, of trying to solve the problem is to just to insist once again with the introducer, the dilator of the septum, and you go. I mean, it goes smoothly later on.
Okay, Ahmed. No, you're muted.
Yeah, so I think this case, we've done. You'll see, balloon was difficult to cross. We redilated then didn't cross. We'll see that. Then we had to make a decision on what to do.
Okay,
So
carry on.
yeah. So pass through the septum. So I think we might have to cylinderize the balloon one more time and try to get it. Otherwise, we might need to dilate the septum one more time. Okay, I think we might need to dilate the septum. The puncture seems to be also a bit posterior. All right, so let's keep this. Let's get the septal dilator. Get the wire. Get the wire. Maybe it's a balloon. I'm going to unlock this one. You probably stuck might have to do a fresh transeptal puncture. Okay. AP. That's a good position now. Okay. Good position AP here.
So can I interrupt here, Jackie?
Yeah.
Jackie?
Good position AP.
So there's one option. I think Dr. Ahmed chose the more difficult, which is to do another transeptal puncture. For this case, I vote for this because if the lateral part of the septum is punctured, probably it's much thicker than the medial part. But there are other tricks. I mean, we can go in with a 10-0 balloon, a short balloon, 10 by 3 or 10 by 4 or something, and we can blow up the septum. This is one other trick to let the balloon inside easily.
Okay, carry on.
Good. Okay. Good position on the lateral. I think we'll do the transeptal puncture here again. Okay. Did the puncture. Okay. Fast. Right. Okay. Inject. All right. Good. So free flowing. You can only see also left atrial appendage. That looks better now. Unlock the first lock. Looks much better. Unlocking the second one. Balloon's inside. And we take him. The balloon almost the shaft of the balloon is translucent. It's not like the regular Toray. This is so Chinese origin Toray like a balloon. There are two things we've noticed. The shaft is very translucent. You basically don't see a shaft, only see the markers. So anti-clockwise is bobbing there, so we close the mitral valve. Again, it's a huge left atrium. See, it wants to jump. No.
Ahmed, your puncture seems to be high, isn't it?
Yes, the puncture seems to be high. You can see that the balloon is coming from a superior position. I think we tried to move away from the other puncture, which was, I think, was low and very lateral, and now it's coming from a high position. But that's easier to deal with, and you'll see in a few seconds what we've done. I do agree with that, Habib.
Play.
So anti-clockwise movement. You need patience. He wants to jump, but you have to. So it's a huge left atrium. So I'm thinking maybe we can. Yeah, make us style it bigger a little bit. So can you focus here? So this is regular curve. Sometimes when it's a big, I give a secondary curve like this, and make it a bigger curve, and I give it like a swan neck shape like this.
It's a huge left atrium in this lady. Looks like a better alignment now. Hopefully this will do the job for us. Slightly inflated.
So Habib, apart from the comment about more superior puncture, are there any other tips for you to try and cross the valve in this sort of location?
I think Ahmed will have hard time to go into the mitral valve with such position, and in that particular case, and that happened to us quite a good number of cases, you'll have to repeat the transseptal puncture and go lower. If you puncture low, then you will go straight in the direction of the mitral valve, and it may. But now, of course, you can make few maneuvers this way, but it's quite it's quite difficult for the operator to go in.
Yeah. Okay, carry on.
Can I comment?
Yeah, Osama. Yeah.
Yes. Another trick is we can use the alternative technique of Inouye himself. Looping the catheter to the opposite side and taking the posterior left wall as a fulcrum, and then here we get the shaft of the balloon mostly in a line with the mitral valve. This is another trick.
Okay,
if I may add, just quick, if we guess this balloon is different. So if you go to it's very floppy. So sometimes a superior is better than actually a low one. Anyway, that stylet shaping where you give a secondary curve when you're coming from a superior position actually works quite well, and you'll see in a few seconds. Yeah.
Okay, let's keep going.
Yeah. Okay, I think we've crossed. All right, good. Inflate distal portion. Good. All right. Fluoro safe. Okay. Now ready for the inflation. Inflate.
Fully?
No. For now, yeah. Inflate butter. Yeah. Okay. Yes. And now finish off. Finish off
now, boss.
All right. Fluoro safe. Are we going to keep the balloon inside now? Okay. Dr. Nafisa will do an echo first. You make sure there's no MR before we go up higher. The valve seems to be opening well. Not much of an MR. Okay. A bit of a small MR there. All right. Can we get a CW through the valve? Okay. So the mean gradient now is?
The mean is 2.7.
Okay, mean of 2.7 and a peak. Okay. Do is we're going to go for an extra inflation. We're still in good position. So we're going for extra inflation.
How?
So we're going to make sure the balloon moves well. Now we can do the inflation. So we're safe? I guess so. So now we can do the inflation here.
Fully now?
Wait. Inflate more, a little bit more. Now it's well anchored. Finish off now. Good. Deflate. All right. All right. Bit of a jerky movement there.
Yes.
But that's fine. Pressure's coming up. That means because we arrested circulation. That's a good thing.
What size did you go up to on that, Ahmed?
Yes, so that part didn't show up. This is we added 2 millimeters, so we went from 24. This was a 26 millimeter inflation.
Okay, all right, keep going.
Ahmed, stepwise technique using the echo to monitor the results of your inflations. Is it done routinely in your practice, or you have done it only for this case?
It's actually routine. I'll comment on that at the end. In our lab, for example, we've been struggling, it's for the last several months, we've been struggling with having two pressure lines working properly at the same time. So believe it or not, it's just getting two simultaneous pressure lines working sometimes could be a hassle where you work. So we have relied tremendously on echo. And I think it served us really well. If there is no MR on the echo, we go up higher, especially with the commissure split. If the split is within the commissures, there is no MR, we go up, and we rely heavily on transmitral gradients using the echo. We, at the end, I'll show you, we'll get a finer transmitral. It has to be one pressure line, so it has a sequential pressure monitor.
I have a related question, Chair.
And left ventral.
Yeah, go ahead.
Yeah, so sometimes we use both pressure and echo, and sometimes the echo result is good. The mitral valve area, it's above 2, but the gradient doesn't drop as well as you'd have expected. Do others have that experience? Where the gradient remains a little higher than...
Oh yes, I do agree. Yes, sometimes we do gradients, even on, even if you have two pressure lines, you have gradients, sometimes the gradient doesn't drop. But the other thing is I want to say, is you want to give the patient the maximum valve diameter without inducing MR. That's our aim from this procedure. The big 1.8 is better than 1.5, and 2.0 is better than 1.8. So also sometimes the pressure is, you get a good result while the transmitted gradient is less than 5, but the valve area is 1.7. And you can take that valve up to 2 without more significant drop in transmitted gradient. So I think imaging is important also because it allows you to take the valve bigger, whereby there is no much change in the transmitted pressure. Because we know if you develop a valve area of more than 1.5 in general in adult, you get very low transmitted gradients, less than 5. But if there is no MR, you can give that patient a bigger valve area without MR, and that gives better longevity to the patient. So I think also, on the other hand, pressures drop, but you can get better results using imaging.
Okay, Ahmed, I think we've got about 4 minutes left, so let's keep moving.
I'll try now. Let's do that.
Down. Zero. Zero.
Yes. The valve looks moving well. Quite good, huh? So let's give a short axis. All right. Beautiful, yes. I think the both seems to be split more on the medial part. Okay. No much of an MR. She's good, huh? Still 4 chambers, make sure there's no wide MR. All right, good. There's no MR there. Okay, it's more or less what we asked. Okay, perfect. There's no MR. And we can... perfect. So next step is to... I think we're still in there. So the question would be, shall we give her more inflation? The valve looks... I think we can give another 2 millimeters. So we go 28 millimeters. Now this valve, if you go by the formula of patient height over 10 plus 10, we're going to give her, this patient will end up as 26. So we give her, now we dial it up to 26, and we're going to up to 28 now. All right, plate. Okay. We're back. A bit more liquid. and finish off here. Floor save, deflate. Deflate.
Ahmed, just one thing.
It's the mean atrial pressure. And now I'm going to quickly shift to the EDP of the patient. And this is the EDP. So I think we have almost overlap of the pressures here. Seems good. I think there is almost overlap. You have to imagine the two lines together. So I think this is a very good result. I think there's almost zero gradient on that. All right, I think we can call this procedure. We can do another echo after we finish. So let's get patient. All right, so let's get the balloon out. Need a stretcher again and the pigtail wire.
Yeah, Habib, go on.
Yes, Ahmed, just
move the other way
two
around.
comments. Did you increase 2 millimeter in a 26 millimeter balloon? So
No, it was 28 millimeters. We generally use
right, okay.
Again, we use it. Yeah.
Okay.
You can let the video. Can we ask the video to play and you comment? Can you mute the video and play it because it's almost done?
Yeah.
Okay. Is it possible, Maher?
Yeah, of course. I can
play the video under mute.
No problem.
You can ask questions. Yeah. Sure.
No, Ahmed, I was just I would like to ask you a question regarding the direction of the balloon when it's inflated going upwards. I think it's good to keep it going downwards with the stylet. So you see what I mean? In one of the inflations, we can see the balloon going up, directing up. And this can sometimes be a little bit risky for the valve. I don't know what's your opinion about it.
I do agree. Yes, I think I do agree. But we were sure because, yes, we tested the balloon, we slightly inflated and we moved it in and out. So yes, we used the pigtail can help you where the LV apex is. We tested to make sure the balloon wasn't entangled. So we do a slight inflation of the balloon and we make sure that it moves smoothly in and out. So yes, always keep the balloon pointing towards the alignment of the balloon along the mitral valve LV apex axis. Keep it there. Yeah, I do agree 100% about that.
Habib, just to follow up on your question then, are you worried that it'll be a non-commissural split? Is that the main concern when it's pointing upwards?
No, I mean, if they're directing upwards, it means that probably not. You are maybe entangled in one of the chordae or something that gives you the wrong direction, and then you might end up by having problems on the chordae.
Yeah. Okay. All right. Ahmed X. Yeah. Go ahead. Final comments.
Oh. Nope.
Last question.
Yeah. Go ahead.
I need to know for Dr. Ahmed, the most stressing moment of this procedure is when you inflate the balloon. What is the percentage of patients undergoing this procedure who develops a mitral important mitral regurgitation and have to go to the operating room to replace the mitral valve?
Yes, I think if you look, it quoted, worldwide with about 2.5, maybe 2.5, 2 to 3% would have significant MR. I think in our setting, we had to resort to surgeons twice, one for severe MR where we ruptured the valve. The other one is due to pulmonary vein laceration. So in about 150 cases we've done so far, we had one severe MR where we had to intubate post-procedure. Patient went with flash pulmonary edema and had to go for surgery. We had papillary muscle avulsion.
Okay, we have almost the same percentage. And even in Tunisia, we have between 2 and 3% of these patients that we operate.
Okay. All right, Ahmed, excellent case. A lot of teaching points, a lot of tips and tricks there. Thank you very much indeed. A lot of hard work there. So that's the recorded case over, and I think we go on to lectures. Is that correct, Habib? So if we carry on, I think it's now going to be Nesma bin Daga from Morocco who's going to talk to us about how to perform a safe transseptal puncture. Nesma, welcome.
Thank you. I'm pleased to participate to this session regarding the performance of a safe transseptal puncture. I will share my screen. So, transseptal puncture is a vital component of mitral valvuloplasty. It must be executed safely to avoid cardiac perforation and made at an optimal site to facilitate balloon crossing of the stenosis mitral valve. Special training is required. Keys for a safe technique are exclusion of any contraindication, understanding the anterolateral septum anatomy and the anatomic landmarks, knowledge, procedure equipment and procedural steps, and knowing how to manage potential complications. It's an absolute contraindication for the procedure if the thrombus is in the atrial cavity or on the septum. The left atrial appendage thrombus is a relative contraindication. After 3 months of anticoagulation and aspirin, the thrombus is resolved in 2/3 of patients. Obstruction or agenesis of the vena cava are contraindications for femoral access. Major thoracic or spine deformity, Hodge, left atrial enlargement, and previous anterolateral septum repair are relative contraindications, and transseptal should be performed by experienced operators. The anatomic anterolateral septum is the anterior area interposed between the two atria and should be distinguished from the true anterolateral septum, which is only the area that can be crossed without going in the extracardiac space, and accounts for only 20% of the total septal area. The fossa ovalis is part of the true anteratrial septum and is posterior and caudal to the aortic root and anterior to the free wall of the right atrium. It's an oval-shaped depression composed of thin fibrous tissue. Its shape may vary according to atrial size, pressure, and tissue's redundancy. In balloon mitral valvuloplasty, a mid-posterior puncture provides a favorable working height in the LA and a coaxial plane with the mitral valve. The usual equipment for transseptal puncture are a press-shaped needle, we use broken brook needle, and a transseptal catheter. Mullins is the most commonly used catheter for balloon mitral valvuloplasty. It's an 8 French catheter and has a curved and tapered distal tip. The procedure, outer sheath catheter, is used by inexperimented operators to prevent catheter's perforation during insertion of the needle. The procedure can be performed safely in the majority of patients with fluoroscopic guidance using several views: frontal, right anterior oblique, and lateral projections. Frontal view is our best view and shows the inferior limit of anterolateral septum. The lateral view is the best for degree of posterior positioning of the catheter. Echo-guided transseptal puncture should be considered in cases of complex anatomy when anterolateral septum is thick or aneurysmal and by inexperimented operators. The disadvantage is general anesthesia. Superior and inferior localization is seen in the bicaval view, and anterior and posterior localization is seen best in the short axis and 4-chamber views. Before starting procedure, assure that the patient is in the strict horizontal position. This is a key to assess correctly anatomic landmarks. The right femoral vein is the preferred venous route for the transeptal puncture, as it offers a direct route between femoral vein and fossa ovalis. The femoral artery is used to position a retrograde 6F pigtail in the aortic root to locate the aorta and monitor aortic pressures. First, we advance a flexible inch J-tipped guide wire from the femoral vein into superior vena cava in frontal view. The Mullins is advanced over the guide wire into the SVC, and the guide wire is removed. Then the transeptal needle is connected to a pressure line and inserted into the Mullins catheter. The needle is allowed to rotate freely while being advanced, without going beyond distal end of the dilator. From then on, it's necessary to hold needle and the catheter firmly and to move them as a unit. To move from SVC to the fossa ovalis, we orientate the catheter towards the left shoulder and perform a clockwise rotation and move downwards and posteriorly. Tipped needle must be located at 4 or 6 o'clock according to the LA size. When catheter tip is in target position, advance gently the transeptal needle so that its tip emerges slightly into LA. The entry in LA is indicated by changes in atrial pressure tracing and the ability to withdraw oxygenated blood from the needle. Once the needle has crossed the septum, the catheter should be advanced in frontal view. After the needle is removed, heparin is given when the catheter is securely positioned in the LA. The transeptal puncture can be achieved with a high level of success and excellent safety. However, several difficulties may arise at various stages of the procedure. Extreme venous tortuosity can make the advancement of transeptal needle challenging. Transeptal catheter inserted inside a larger sheath, more than 2 French, which will provide support and facilitate navigation. Severe kyphoscoliosis, enlarged left or right atrium, and dilated aorta can pose significant technical challenges. These challenges can be successfully overcome using larger curved transeptal needle and imaging guidance. In the giant left atrium, ideal puncture sit is lower than in moderately enlarged LA. When the needle tip is placed on the optimal point, the balloon is easily crossing the mitral valve. When the needle tip is placed on the higher side, it's difficult to puncture the septum, even if the puncture is successfully. Insertion of the balloon across the mitral valve is difficult. Several anterolateral septum characteristics can lead to difficulties in gaining access to the left atrium. When septum is thick or aneurysmal, the mechanical force that needs to be applied to cross the septum is higher. The risk of failure technique and cardiac perforation may be higher. Solutions are holding firmly the needle with both hands and twist it clockwise and counterclockwise. We can also use sharp-tipped wires through the needle to facilitate needle crossing, or use a radio frequency transeptal needle. We don't have it in our cath lab. The heart perforation may result in mild pericardial effusion, but tamponade may occur. Perforation of the coronary sinus is the common seat and need frequent surgery. A sudden jump of the needle can lead to perforation of LA roof or posterior wall, especially in cases of thick septum and small LA. In lateral edge of LA shadow, there isn't anterolateral septum. So the needle moves from the RA to the LA through a pericardial recess. It's a stitching phenomenon, and tamponade occurs after with withdrawal catheter. Finally, aortic root perforation is a rare life-threatening complication. If only the needle enters through the aorta, withdraw the needle and wait and see. If the catheter entered to the aorta, don't withdraw it and go to the surgery. The tamponade is most common cause of death during transseptal puncture. Early diagnosis by TTE in cath lab and urgent treatment with pericardial puncture and reversal anticoagulation is life-saving. If massive hemorrhage, surgery is required. Peripheral embolism or embolic ischemic stroke may be caused by thrombus or by air. Its management depends on location and entity. Prevent these events by careful flashing and proper intraprocedural anticoagulation. Conclusion, the growing number of indications for transseptal puncture need for precise and safe technique. Training is very important, starting with simple cases following basic rules. TEE guidance is in unusual anatomy will make this procedure very safe. Thank you for your attention.
Thank you very much indeed, Nesma. That's, again, brilliant talk. It's summarized pretty much a lot of things we discussed with Ahmed's recorded case. Are there any questions from any of the panelists or Emmy from attendees?
Yeah, just a brief one, Chair. Nesma, you didn't mention whether a lateral view should be used during the transseptal. Do you recommend use of a lateral view or just the frontal view, the AP?
We use only frontal view for transseptal puncture, and right oblique anterior for the when we want to cross the balloon in the mitral valve.
Chuck, I have one comment if you allow me.
Yes, go ahead, Osama.
We discovered another way to puncture the tough septum other than radio frequency. Very simple. You just connect to the electrocautery. You connect the needle, the transseptal needle, to an outside electrocautery machine, the same the surgeons use or we use during pacemaker implantation for control of bleeding. So you just connect it and give it an electrocautery, a cutter choice, and how we can push a little bit. This will go a snap inside the left atrium.
Any particular energy you use, or is that?
It's electrocautery, the usual, you know.
Okay.
But it's just interesting and available in our cath labs.
Okay. Any other attendee questions, Emmy?
No, just a rebuttal to Dr. Osama. Does the puncture heal when you use electrocautery? Because normally the punctures we do when you use manual force is that it should heal. This one, when you use cautery, does it heal?
Yes, it heals. They're just like the atrial puncture you do without even cautery. Any injury to the septum will heal within 3 months in 2/3 of cases, as the reported literature.
Okay, Habib, you were going to comment?
Yes, I wanted to mention something. I mean, the first slide of Nesma has shown a picture of someone who is a leader of balloon mitral valvuloplasty. That lady on the right-hand side of the first slide, that's the mother of Nesma. And she's a very well-known interventional cardiologist who has promoted balloon mitral valvuloplasty, not only in Morocco, but in North Africa and beyond. Madame Naim Al-Haytham, I just would like to remember her and thank you very much for supporting Pafcic for many years and for transmitting that to Nesma now.
Nesma was being very modest and not acknowledging her mother.
Yeah.
Okay, thank you very much, Nesma. Well done. Let's move on, and it's my pleasure to welcome our host now, Habib, who's going to talk to us about balloon mitral dilation, state of the art. Habib.
Thank you very much, Shak. It's really a pleasure talking about this procedure that looks a little bit old-fashioned, but I think it has been useful for us for many, many years, and it's still useful for many young patients. And that's maybe one of the main differences between what we offer to, of course, we don't make the difference, but this procedure is very, very helpful in young patients. Do you see my slides now?
Yes, we do.
Okay.
Yeah, we do.
Oh, sorry. No, this is not the right one. Sorry. So I have to close this. I have to close this. Okay. So I have no disclosure for that talk, and I just would like to show you this slide. It's quite old, but it shows the prevalence of rheumatic heart disease around the world, and you can see in blue the high prevalence of RHD in Africa, and particularly in sub-Saharan Africa. So it is a big problem, knowing that rheumatic heart disease is the main origin of mitral stenosis. Now, this disease has been over the years. It has been treated by closed heart commissurotomy and then by open heart commissurotomy, and thanks to Inouye in 1984 with a percutaneous approach and the percutaneous balloon mitral valvuloplasty. There has been a comparison between surgery and balloon in the early years in 1994. You might remember this famous trial comparing balloon versus open surgical mitral commissurotomy, showing a quite equivalent effect, although maybe a slightly better result at 10 years of open surgical mitral commissurotomy versus balloon mitral. In Monastir, we have conducted a quite similar trial. It was a randomized trial between closed, open commissurotomy and balloon mitral valvuloplasty. It has been published late in 1990s in Circulation, and it has shown that in black, closed mitral commissurotomy is associated with much good results than open mitral commissurotomy or balloon. What you see here in white and just next to it in gray are open mitral commissurotomy and balloon mitral valvuloplasty, and the results at 7 years were equivalent, as opposed to a less good result with closed mitral commissurotomy. Now, what are the techniques that have been used for this procedure? We have started in the early years using the double balloon technique, and then we have the multi-track technique, the Philipp Binhofer technique, which was actually 2 balloons, but with 1 wire. And then we switched to the Inouye balloon. Actually, we went back to the Inouye balloon because we realized that this is a safer technique. We don't have to deal with the LV apex and the risk of LV perforation. And Inouye balloon technique is nowadays the technique of choice. In the meantime, and because of the high cost, Alain Kribi has developed a metallic commissurotom that is an inspiration from the surgical commissurotom that has been used by the surgeons for many years. And this device has been used for maybe a few number of years, and it has not gained a lot of popularity. We have used here in Tunisia, but it turns out that it's quite bulky. It's not very easy. One of the advantages of this technique is to be able to be sterilized because it's a metallic device. But again, it's not really friendly user. It has not gained very wide acceptance among the operators. And I know that it is maybe a little bit used now in India and perhaps in Egypt. Maybe Usama can correct me later on. So I just would like to show you the case of a patient, 46-year-old female, who has a rheumatic valve disease known since 1994 with recent symptom worsening. The echo findings show severe mitral stenosis in mitral valve area of 1.2, but associated with tricuspid stenosis. This association is not very frequent, but it can happen with a gradient between the RA and the RV of 9 millimeter of mercury and moderate aortic valve disease. Severe pulmonary hypertension was associated to these findings. Now, I will just show you the way we do it, the way we do transceptor. We make the descent in the EP projection, and then we take a look on the RAO, and then we make the puncture systematically in the LAO on the lateral projection. And one of the reasons is safety. We have the aorta here, and we have the posterior wall of the left atrium here. So we try to avoid the aorta. So we go a little bit lower than the aortic root, and then we try to point the needle a little bit posterior, and then you will avoid actually any puncture of the aortic root. And then once you're sure about that, you advance under pressure, monitoring the needle, and then you advance everything. Now, once you're there, you introduce your wire. I don't spend time with this, and then you dilate. Sorry about this. You dilate the septum, and then don't worry, it will turn out gray as usual. Okay. This is the first inflation at the level of the mitral valve, and then a second inflation, not a good position, but still optimal. And then after that, we had a quite good result by echo, and then we switched to the tricuspid valve. This is the pigtail catheter using the same in-way balloon. This is not a very good position. This is a suboptimal position of the balloon, as you can see here. So it's directed towards us, which is not the right direction. This is the optimal balloon position. I will show it to you again. Tricuspid valve also successfully dilated in the same time, and mitral valve area increased from 1.1 or 1.2 to 1.8. MR almost did not change, less than grade 1. Tricuspid gradient went down from 9 to 4, and TR, however, and that's one of the risks, TR increased from grade 1 to grade 2. Now, what are the results of balloon mitral valvuloplasty that you know? One of the big groups that have published a lot about the subject is the BISHA group with Alec Vahanian, and these are the results of the immediate results going from 1988, when the procedure has started to gain acceptance, up to 2004, and you can see that we have a success more than 80% of a good immediate results, defined as mitral valve area less than 1.5 without NMR more than grade 2. Now, complications, and I think that was a question by Dr. Amin Jamal a few moments ago. In hospital death, very low, 0.4%, tamponade 0.2%, embolism with sequelae 0.3%, and severe MR, it's maybe between 3 and 5%. It's maybe getting less since we have been using the stepwise technique with the in-way balloon. Now, long-term outcome of balloon mitral during pregnancy, again, this is what we have published a few years ago. Actually, we published more than that. 61 pregnant patient, that was the series that was published in Neurointervention in 2006. Mean age 28, they had balloon mitral during a mean gestation of 26 weeks, and the procedure was successful in all the patients. Delivery at term, at a mean gestation of 38, so a normal gestation time. And those patients, they've delivered vaginally, which is really important, in 95% of cases. And the few patients that had a cesarean section, that was just because of obstetrical reasons and not because of their mitral stenosis, no fetal suffering was observed. We have followed up those babies up to 11 years and even longer. Now we have the longest at 20 years. We have looked at their weight, their height in girls, in babies, and we controlled that to a control population, and there was no difference between the two. And we have even compared the IQ, because it was suggested that maybe X-ray radiation during pregnancy could actually affect and could result in mental retardation. So we have compared the IQ of these babies to the control population, and there was no difference between the two. Now, the results at 20 years, again, this is the BISHA series by Alec Vahanian, published in Circulation 2012. At 20 years, you still have a good result, although you have a mitral valve replacement or other procedure in 62 patients out of 1,000, so it's not that high. But let me just show you this curve. At 20 years, the survival without surgery or repeat balloon mitral valvuloplasty was observed in about 40% in patients who had good immediate result, and it's much less in patients who had poor immediate results. So patients who don't have good immediate results, most of the time they will end up by having a balloon mitral valve replacement a few years later. Now, survival without surgery or repeat balloon, and in functional class 1 or 2, New York Heart Association, a little bit less, 32% at 20 years when you have obtained a good immediate result. Now, of course, it is really important to have those results, but it's even more important to try to find if there's any way to predict the result. And BISHA group, again, they have developed a score based on age and final mitral valve area, valve anatomy and sex, rhythm and functional class, and final mean mitral gradient. I would not go into the details of that. By the way, we're working also on a score which is different from that one, but I think it's quite interesting and important to have a score in order to predict the results. For a patient, for example, who have a score between 3 and 5, the prediction, you will have 81% of good results at 5 years, 65% at 10 years, and 15% of those population, they will still have a good result at 15 years. Now, how about patients who have calcification? This is an interesting paper that was published in 2014, just to show you that actually group 3, what you see here, is the group of patients who have at least one commissure significantly calcified. These patients, they do have much less good result than patients who have no mitral valve calcification. It is obvious. But still, you will have 73% of this population who still can have advantage of the procedure. And you can see it here. Again, this is the BISHA group showing that if you have a calcification of grade 2, 3, and 4, you will have less good result than if you have calcification of grade 1. But still, up to 14 years, you will have 20% who have good functional results. So it is worthwhile to start and don't refuse the patient, decline the patient just because of calcification. That's the bottom line. Now, repeat balloon mitral valvuloplasty, again, it's worth it to do it. This is the result of the Buletti series, and you can go from 1 square centimeter to almost 2. So that's the usual increase of mitral valve area in patients with mitral stenosis. So repeat balloon mitral valvuloplasty is widely accepted, and you can have a similar good result as for the initial procedure. And it is the case whether the patient has already before a closed mitral commissurotomy or open or balloon. So whether any kind of previous commissurotomy is not a contraindication for repeating the procedure. These are the guidelines of the European Heart Journal of the ESC that was published in 2017. I would go fast just to show you that even in patients without symptoms, but who had at a high risk of embolism or hemodynamic decompensation, they might benefit from that procedure. So the indication, of course, is if the patient is symptomatic without unfavorable characteristic. But one point here, patients should be considered as initial treatment in symptomatic patients with suboptimal anatomy, but no unfavorable clinical characteristics of PMC. And that's 2A. And then patients who are asymptomatic without unfavorable clinical and anatomical characteristics for the balloon procedure, if they have high thrombotic risk, or they are at high risk of hemodynamic decompensation with pulmonary hypertension or a desire for pregnancy, it's a 2A indication to do the procedure. So in conclusion, mitral stenosis remains a public health problem in many developing countries, particularly in sub-Saharan Africa and South and Central Asia. This procedure has become the therapy of choice in patients with mitral stenosis. It is very safe procedure in experienced hands, even in unusual settings such as pregnancy, and long-term outcome is very satisfactory, particularly in patients with favorable anatomy and good immediate result. Scores for patient selection and long-term outcome prediction are very useful and need more refinement. And finally, current data support the broad use of this procedure, even in patients with impaired valve anatomy, but who have favorable clinical characteristics. Thank you very much for your attention.
Thank you very much indeed, Habib. Excellent state-of-the-art talk there, and a lot of information. One very quick question, you addressed it briefly as well, and that is there a limit to calcific mitral stenosis where you should not attempt balloon?
To be honest with you, Shaq, we did decline patients with mitral regurg. We're afraid of increasing mitral regurgitation if it is, just there, significant, maybe grade 2. But calcification, we're not afraid to give it an attempt and do it. Okay. I rarely recall of any patient who was declined just because of calcification. And again, we have surprises in terms of results, at least immediate results. These calcified valves, they go down, actually, they restenosis, but still you can improve symptoms for at least 1, 2, 3 years.
Any other questions from panel or
good question.
attendees?
If you don't mind. Habib, how do you see the new technologies affecting mitral valvotomy? There was a recent a publication in Eurointervention on the use of steerable guide catheters to deliver cylindrical balloons through the mitral valve and perform mitral valvotomy. They even used an LV wire that used to pace the heart during mitral valvotomy. So the newer techniques for the new mitral valve procedures, do you think that we might see change in the future using the same technologies for mitral valvotomy, making it easier? Steerable guide catheters, cylindrical balloons, pacing the LV while we're doing that?
To be honest, of course, we have to know better this new equipment. But, Ahmed, we're happy with what we have. And we're not able actually to expand this technique and have patients benefit from it already with the way we do it. And I don't know if you need anything else at the moment. What you need actually is to have this kind of technology, but at more affordable price so that more patients, particularly in limited resources countries, can benefit from it.
Can I have a comment, Dr. Habib?
Yeah, Osama first.
Yes, thank you. Thank you very much, Dr. Habib, for this comprehensive, very gestaltic look to the mitral stenosis. I just have a few rapid comments. The first is that in our country, Egypt, we were probably the first in the continent to start. We started as early as 1988 and published a few cases. And then we, around 2,000 cases were published in the late 2010. So we have a large experience, just like in Tunisia. I'm wondering, we have developed a score, I named it after my name. It was published in the echocardiography in the year 2009. So, and we thought that if it is commissural calcium bilateral, forget about the procedure. If it is unicommissural calcium extensive, again, it will end by blowing up the other commissure with severe mitral regurgitation. That's the essence of the score. And finally, the subvalvular disease. If it is there, really there, even with no calcium, you can blow the valve subvalvular fibrous tissue and then get, again, severe mitral regurgitation. The final comment is that we have already published redo balloon mitral valvotomy. This was 2012 or something. It's going the same result. Personally, I have 10 cases done for the third time, and the same result. You got the same sealing of the mitral valve area. Once you reach 1.5, for example, 1.8, and then it goes back to 1, and then 1.8 finally, it's the same sealing. You much more better, but it gives him 10
seem to have lost
Molesta.
Osama. Ruben, you had a
Yes,
question or comment. Go ahead.
sure. So just about wiki score. What is the cutoff? We know that the good results is about 8 and below, but how can you go? Is it up to 12, 13? What is your experience, Professor Habib?
You're talking about the Wilkins score? The Wilkins? Are you talking about the Wilkins score? The Eco Wilkins score?
Ruben, you're muted.
Wilkins. Echo Wilkins score.
Wilkins.
Yeah. Okay. Yeah. As I just said, I mean, we of course rely on that, but we still give it a try. I mean, many of these patients, they're young, and just give them the benefit of the doubt. And sometimes you just offer them this procedure, and you can, offer them few years actually of improvement in symptoms. And of course, ultimately, these patients, they will end up by having mitral valve replacement. But still, if you can keep have them gain few years, I think it's good for them.
Okay, Habib, thank you very much. I think this has been an excellent session. Great recorded case, and then the talks. Can I pass the last comment to you?
All right. Thank you very much, Shak, and thanks, Ahmed, for this great demonstration of how we do safely balloon mitral valvuloplasty. Thanks to Nesma, thanks to all the panelists for contributing, and the attendees, of course. We have a break, actually, for about 20 minutes, and then we'll go back with a live transmission from my center. So I'm going to be scrubbing for the septal ablation of hypertrophic cardiomyopathy. And I hope everything will be ready, because we're going to have a remote proctoring from Iber Sigwis in Germany. So he's going to be following us step by step what we do, and hopefully everything will work out safely. Thank you very much. See you.
Thank you. Thank you.
Thank you.
Thank you.
Thank you.
Bye.
See you.
Okay, see you.
Bye, everybody.
Bye.
Bye.
Thank you.